Yes, so we now start our panel. So the first question is actually, we start with the systemic therapy and radiotherapy, and then we will finish with questions about the surgery in early stage non-small cell lung cancer. So firstly, you know, the results of treatment in the stage 1 non-small cell lung cancer are better and better, especially if we are following the patients with second, third, fourth round. Then the results that has been shown by I-ELCAP treatment of stage 1 non-small cell lung cancer is 90% 10-year survival. So do you think that this is reasonable to still look for neoadjuvant, adjuvant or systemic therapy in this stage 1A patients? Or should we just leave it and don't do anything more about that? This is a question to Natasha.
Thank you. So I think we're already starting to see some signals of benefit. Karen showed some nice data suggesting that chemotherapy, especially for those higher risk stage 1A patients, may have benefit. We've seen some targeted therapy trials where we're starting to see signals emerge. So I think the answer is yes, there is potential benefit and we should study it. I guess the other question is, should we be more creative, right? So we were talking earlier about canakinumab, checkpoint inhibitors, this sort of secondary preventive concept where, you know, we failed with vitamins and different things, but, you know, is this where we should be looking at anti-inflammatory agents, immune modulatory agents, as well as, you know, old school things like targeted therapy and chemotherapy, and even sort of anti-PD-1. So I do think it's important. I think it makes a difference. And I think we should do more trials. And I really like that concept of the screening teams getting together and having that initial platform where then you attach interventional trials to your outcomes. And I think this would be a great group where you could organize that because, you know, you have the screening, you have all the different teams in different parts of the world. You can attract that level of investment that's required for the interventional piece. So I think it's definitely worth it. I think we have to do it. You know, today in Poland and many other countries, most of what you diagnose is not stage 1A, but you're changing that. And so in my institution, it's 40% 1A, 40% 4B and C, and everything else is just a very small group. So I really think we need to invest. That was very wordy, but I'm going to turn it over to
Suresh.
I think you've raised a very valid question because in the patient group that undergoes stereotactic radiotherapy, I think the adjuvant trials have been, or the combination trials in very early stage have been disappointing. So we're talking about a group with comorbidities, often elderly, who come for stereotactic radiotherapy. There were 3 phase 3 trials. 2 of them have reported, not fully published. So one was with pembrolizumab, the keynote study was stopped for futility and excessive toxicity. The second one was an American intergroup trial in the inoperable patients, and that was with atezolizumab, and that was stopped. And the third trial was mentioned yesterday. It was a Pacific 4 trial, which should report, but rumor has it that it's not. So my take on that is the patient group you're talking about is fairly frail, and immunotherapy may just be too much of a good thing. So it might be better to wait for the subgroup of 10 to 20% who may recur later on and then take it on. Having said that, I think that's for immunotherapy. And I think as we go into the molecular targeted era, the situation may change.
I agree with that. And the issue is that we have patients with very different biologies. So you'll have patients with KRAS mutations for whom we know that the future wave of new drugs will be KRAS inhibitors. And these drugs may be very effective in specific KRAS-positive population of patients. So we will see in the future. The problem, however, of comorbidities and competing risks is huge. And that's why the potential benefit from not optimal local control, but close to optimal local control, versus comorbidities makes this task especially difficult.
The next issue is the novel therapies, because I'm wondering if, Rafał, this is maybe first for you, because I know that you are doing this, so you participate in several adjuvant radiotherapy trial with personalized vaccines. So do you think that vaccines will play the or could you precisely define if what are your expectations with vaccines in early stage lung cancer, but not only, but mainly we are focused on early stage, but we are also talking about in general.
I'm quite a believer in vaccines, actually. There are many agents now being evaluated. They are smart mRNA vaccines that can be either tumor-informed or uninformed. And I can see at least that participation in clinical trials with these vaccines, either as adjuvant, neoadjuvant, and potentially in very early stage, may be a solution. We have to wait, of course. Now we have nice biological data showing us that these antigens that are coded by these vaccines, we see a robust immune response against them, so that remains to be seen. The question is, again, in which space neoadjuvant seems extremely interesting for me, just to increase PCR rates of patients that are operated, especially in neoadjuvant window, and these trials will tell us a lot. We have a couple of them, actually, in Gdańsk together. So
when do you expect? When do you expect have vaccines in routine use?
No, it's a question of phase 3 studies. Some of these we now have a bunch of phase 1, phase 2s, but phase 3s are also ongoing already. So we should see that within 2-3 years.
I think, I think we're all very excited about the personalized vaccine space. I'm a little bit worried about single agent activity, especially when some of the benefits are much longer term. So we do want to make sure that we don't throw the baby out with the bathwater. But we have seen trials where, you do see prolonged survival. When you add it to immunotherapy, even if it's the flu vaccine or the COVID vaccine, people have better lung cancer outcomes. So I agree with you, Witold. I think this is a very exciting area, including for secondary prevention. You might need a little bit more to kind of tip people over. You might need one dose of immunotherapy, but I think again, we really do need to be very thoughtful and reimagine things for this early stage and screen-detected lung cancer space, because you're quite right, it's not the same as a stage 4 space where you just throw all the drugs at people and expect the risk-benefit to be there. I don't know, Suresh, if you're more enthusiastic about vaccines?
I will ask for the next.
Oh, I'm sorry.
We have to move forward. Many questions, also surgical questions at the end. Summary. But I have a question about the study that was performed by Nasser Al-Turki group when he, in stage 3A non-small cell lung cancer, conducted the study with immunochemotherapy plus SBRT on the tumor left N2 nodes untucked. So, what is the rationale back this concept? Do you like this concept? And do you think, and then should we maybe leave the lymph nodes in lung cancer surgery untucked?
To me?
Yeah.
Okay, so I think Dr. Al-Turki's study was very interesting because treating only the primary tumor, giving durvalumab as preoperative, and he found nodal downstaging in patients who had pre-existing N2 disease. I think further work from the Chinese group, which performed the Section 1 trial, presented at ESMO and published, was also interesting because they gave chemo-immuno, low-dose radiotherapy to only the primary tumor, and they found a fairly high incidence of nodal downstaging. So I think the translational science is not out there yet fully, but if you could prime the immune system with this sort of preoperative low dose, then the question is, could you actually add something to full dose chemo-immuno before definitive local therapy? So I think it's very promising because one of the speakers mentioned about de-escalating therapies. And if you're already going to get a local therapy like surgery, and you want to improve, for example, in the PD-L1 negative patients, or in subgroups which do less well now, it's worthy of trials. And I know that some trials, at least in discussion stage or early development stage. So lighter radiotherapy, immunotherapy, and then a definitive local therapy without prior treatment of proven nodal disease.
Should we go further this way? Follow this, or?
I would like to see a phase 3 trial, and I think the detail will be in which subgroup we choose. If, for example, it's a subgroup that's going to get a very high complete response rate with chemo-immuno only, I don't think that's the correct group. It might be a group which shows some resistance. But if you can show evidence of priming the immune system for longer and durable anti-tumor activity, then it could be a sort of immune, a sort of vaccination strategy.
I agree, and phase 3 is ongoing already with the Chinese colleagues. They proceed with the publication of phase 2. They are already doing phase 3.
Rafa, we plan to do that. What with our plans?
Yeah. And we also have plans to do a pilot study with that.
So we've been doing immune checkpoint inhibitors with 3 doses, 3 fractions of SBRT, and we weren't expecting to see Nasser's fabulous results. We've been very impressed. And these are in superior sulcus tumors, right? Everyone was very nervous about not having, chemotherapy. So I think I think that strategy has legs. Well, but I agree, we need to see the phase 3.
Thank you. And the question about the antibody-drug conjugates. Do you think that there is a place for these drugs or these specimens in the early stage, but not only in early stage, and maybe, I've learned a little bit about them. And I thought maybe this is the way to treat the multiple lung cancers. I mean, especially multiple subsolid lesions that will evaluate in lung cancer. What do you think about this concept?
So I love Karen's shown some nice data of ADCs plus checkpoint inhibitors, and you get a nice response rate preoperatively. ADCs, I think, are still chemotherapy 2.0, right? You have the targeting, but 95% of the drug is released in circulation before it ever hits the tumor. So I think we need to improve the linker chemistry so we get better delivery to the neoplastic sites. I think we need better payloads. Right now, it's all camptothecins, which are very old-fashioned, lots of lung toxicity and interstitial lung disease. So I'm worried about the current generation of ADCs in this population. But it is changing, and it's changing fast. So I do think there will be a future where you could request certain types of payloads that would be less lung toxic. You could request better linker chemistry, and then you could ask for that KRAS targeting. You could ask for, even, if there's some differential proteins that could be expressed, or in particular, it's the cells that take up the ADCs, which are not necessarily the ones with the target. So I think once we figure that out a bit better, then I think you'll be ready to go. But I think for early stage, we need smarter chemistry. I don't know what people think about that.
And the short question about, I don't know if it's provocative or not, but what about thermoablation? This short question to all. What do you think about, ablative techniques? Do they have a place in treatment of early stage lung cancer?
Me? Yeah. My, oncology mentor told me there are only 2 radical treatment. One is SBRT, another one is surgery. So ablation, my mentor told me that it's all palliative.
Well, our data show that you get fairly good local control, fairly good at 2 or 3 years. You don't have a lot of that after that. So I would rather think it's a good option for high-risk patients, and you forgo the risks of radiation therapy. But for the rest, I would rather stay on.
But I'm curious. I want to listen to the radiotherapists and also, and of course, Natasha, you are welcome.
With my
very much.
academic hat, we are taking part in the ablate and resect trial prospectively, which Dr. Leighl is also accruing a lot of patients to. I think we need the science. And indeed, with the older microwave and radiofrequency ablation trials, indeed you had in the scars the chance of later recurrence. So I think it's a good situation. For example, we see a lot more patients with interstitial lung disease or ELAs. And that group is changing. I think there may be something which we do, but our surgeons now perform NITS, non-intubated thoracic surgery, so that would be a competition for ablation. So I think once it's established and the early local control rates are better defined, there might be a place in some groups.
You know, another question, you know, after ablation and, you know, there's a nodule there, sometimes it's very difficult to make clear diagnosis. Is there a scar or the tumor left?
Same with SBRT. We had the same questions in the past. Not anymore, of course.
Yes, I think that we have elaborated on the radiological features of progressions after SBRT, but it took some time and it's still not so easy. The endobronchial approach is quite interesting because my traditional thinking is that by traditional transthoracic approach, you get to these complications that still exceed the potential benefits as compared with SBRT. But I have to say, with the revolution of endobronchial navigational technologies, this is again to be revisited.
I have to say, as a medical oncologist, there's still a significant proportion of patients with comorbidities that are referred to me because traditional local therapies are not an option, including radiotherapy. And, you know, we don't do enough ablation at our center in Toronto, so Dr. Leighl, we would love to have you come and send trainees or fellows. But I really think, you know, especially the interstitial lung disease world, we see a lot of that in the screening. I mean, I think these are options that patients otherwise just can't get. They come to me, I can't give them drugs because even the drugs are too toxic, whereas an approach like yours could be helpful. So I think there's definitely room.
Well, so we can hear rethink. 5 years ago, it was not possible to hear about that from radiotherapist, at least. Okay, so we switch now, and Clemens start to ask the questions.
What I would be interested, particularly in the oncological opinion, we're talking about immunotherapy, targeted therapies in stage 1. Do you think we will move into an area where we will require molecular profiling of all early stage patients prior to therapy initiation?
So I agree that the level 1 evidence or the phase 3 data are what really drives the world to do the NGS testing. But I guess we should also flip the question, you know, when I was putting those slides together, I mean, doesn't it just make sense? So especially in places like Asia, where you do see so much EGFR-driven disease, shouldn't we just be testing? I mean, I agree, you could say in these public systems, first you need the evidence, you need the treatments, then you test. But in an ideal world, I think we would test, wouldn't we? And so I think, you know, we're even in some centers moving to whole genome rather than just limiting to sort of limited panels. So I think we need to start thinking differently about more profiling, certainly in a research setting. But I do think that in time with vaccines and checkpoint inhibitors and more tolerable inhibitors of RAS-driven tumors, for example, in early stage multifocal disease, that we will need to do it. So I think we need to start getting ready. We need to do it in the research setting for sure. And then we will drag the policymakers along with the phase 3 data. That's mine.
I think the very interesting topic in this group particularly is chemoprevention, secondary chemoprevention. There's still few trials addressing this very important problem. And all the work that was done in the past was very different because we didn't know so much about biology. Right now it's very different, so why not address this issue more within our plans for prospective testing? Sanakimumab is the best example, of course, the drug that can be eventually tested in this field, but this is a field that is extremely important.
You mentioned when you were talking about the radiotherapy versus surgery trials, both the STARS as well as the ROSAL trial and the ARTOC trial, they were poorly recruiting, whereas the VALOR trial now recruits very well, apparently. What's the difference? Why did the initial trials recruit so poorly, and why is it working now?
If I could make a comment. So the VALOR investigators contacted me and I said, why are you doing this? So the PI explained to me that the VA surgeons are salaried. They're not paid per procedure. And the second thing is that if CT screening took off, this was years ago, it may be different now. He said if CT screening takes off, they may not see their wives and children during the week anymore. And the VA has also got a very proud tradition of establishing standards of care, like in head and neck cancer. So that academic drive is high. And I think they should be given credit for doing it in a patient group which can undergo curative treatment. The rest are all opinions. But the only two good sources we have for evidence in pathology-proven cases are the MD Anderson extended study, which also led by Jack Roth, stimulated that, and the I-ELCAP data with about 100 plus patients of the whole 1,000, showing high local controls, and the lung cancer specific survival was the same. So those are the only two studies we can cite now, but I think it will be in about 3 years' time for the readout for VALOR. And, you know, somebody's got to do it, and I hope the VA gets the credit for completing the important trial and giving us the answer.
It's going to be interesting. So we have very good evidence now that minimally invasive surgery even improves survival compared to open thoracotomy. You've shown the data. Eric Lim presented at the World Lung Conference. Actually, the full paper was published just yesterday in the Lancet, so it's available now. And however, the evidence, what should we do, wedge versus segmentectomy versus lobectomy, seems after the two large prospective randomized trial and another smaller prospective randomized trial still under debate. Or can we give a clear guidance what to do in what situation? For both of you, Min.
Yeah, I think there are several trials to cleared to demonstrate what the indication for wedge resection, for segmentectomy. There are two trials, CLDB 14-0504 and JACOG 0802. You know, there are always debate. You know, for even the JACOG PI, trials PI, Dr. Hazard Mullah, he still, opposed the segmentectomy, even, based on the data. There are 5 years is superior segment, and the 10-year survival rate almost equal, but segment is still a little bit better than the segmentectomy. So, you go back to see the data. In the local recurrence, segmentectomy about times high. That's because the indication is compromise the procedure. If you do a well-indicated segmentectomy, there are no doubt there will be a better result. So all the, you go back to see the detail, all the segmentectomy is compromised procedure. So we need to follow the full indication, give the very enough margin, we can overcome the local recurrent higher compared to the lobectomy.
Yeah, we need to say that the data that I've shown are not published yet. I think they are still arguing a lot about what to say in the end. Another consideration is you did have a significant, although not that great, but significant survival advantage at 5 years. We have to remember we are dealing with mostly elderly patients, advanced age and high comorbidity burden anyway, because they are smokers, because they have a lot of competitive disease. So I believe that even a small advantage as 5 years is something significant. And also I agree with Dr. Chen. It's mainly a question of technical details and skills. You have to do it properly. And if you have wide enough margins and you do a nice clearance of lymph nodes, then you're going to get good results anyway. I can tell my own experience is not that high local recurrence rate. So maybe that you need to fine-tune your surgical technique for that. So I do believe there is room. And lastly, as I said before, the only indicator of functional gain for them was FEV1, which is not so good, I think. You should remember that when you take out a whole lung, you take out a quarter of blood-air barrier surface. If you go for less resection, you take out a smaller portion of the blood barrier exchange area. So this should translate in something better.
Well, but practically, if you the last update of Japanese trial showed two things: that no difference in long-term survival between segmentectomy and lobectomy, and the second thing that still the same result concerning the recurrence, more recurrences after segmentectomy. So don't you think that if the recurrence rate is higher in segmentectomy group, so we should also take into consideration this fact and do lobectomy instead of segmentectomy?
That I mentioned, and, you need, there are very good indication for, it's not good for, do segmentectomy, not, just because the location, or you don't get enough margin. That's for the main reason. I personally discussed with Dr. Samura about
so margin is
margin, indication margin, very important.
The margin is a key, and one other key issue in the trials was negativity of lymph nodes. In the North American study, it even had to be verified by frozen section. This is something I think which is for the real world experience an extremely important issue. Now with the GGOs, your study suggests there are no lymph node metastases. So in what situations should we proceed with doing a lymphadenectomy, and when can we omit that?
Yeah, even the invasive adenocarcinoma is GGO dominant. That means if CTR ratio less than 0.5, you don't have to worry about mediastinal lymph node positive. We've never seen 0 cases lymph node positive.
In GGO, pure?
No, CTR ratio that's less than 0.5. And also, they're greater than 0.5. We never seen cross mediastinal lymph node positive. If the Japanese Dr. Samura, I think he read a paper in 2005 and mentioned the lobe-specific mediastinal lymph node dissection. That means if in the upload you only have to do the up mediastinal lymph node dissection. That means not apply for the solid tumor, but for the GGO tumor, invasive CTR ratio greater than 0.5, that's applied for.
Anything to add?
I think it's reasonable. If you have very little solid component that they measure, that CTR is, the ratio between hazy and solid, And if that is low, the probability of having lymph node metastasis is very low. It's basically it's zero, so you could do without it. Normally, I think it's difficult for a surgeon to leave everything there. Once you are there, you take some lymph node, at least a sampling you normally do, unless the patient is frail. But if you have a solid component which is predominant, then you should go for at least for a lobe-specific lymphadenectomy, at least for that.
So the question is, when we're talking about pure GGOs without any solid component, should we resect at all?
This is a good question. They are investigating it. But it depends on, again, age. We know some patients will have visible GGO lesions. I've shown a case like that. Well, she was in early 60s, late 50s when it turned out to be, and now she's 65, she's retired. Okay, nothing happened so far, but maybe tomorrow it will start growing. We don't want to lose the window of opportunity, so we keep following.
I just want to mention to the non-surgeons that to do lymphadenectomy, proper lymphadenectomy, this is the second operation. We stop doing the segmentectomy or anything, and then it's lymphadenectomy. This is not the add value. This is a time-consuming procedure with complication also rate, which is a little bit higher than in normal. But that's why we're discussing it.
According to current standard, it's a routine procedure in any lung cancer operation, and omitting it would be a change of practice strategy.
If I could just comment.
As you can see, there is perfect agreement between surgeons, okay?
Yeah, as I mentioned, if a pure GGO, no matter, it's stable, no growing, just leave alone. Why you have to operate on patient? Slowly growing, that means you have relatively wider, we call it curative time window. If slowly growing, that means it turns out to be over 95% malignant. So you need to compare how long the patient, without this disease, how long he would live.
And I think this is a missed opportunity that we must take advantage of. Why should the intervention be watching with follow-up surveillance imaging when these people could be on prevention trials, right? So I really think that this is the group where we really need to think about what's the biology, what makes sense, what's tolerable, and do these trials of prevention, because these are groups, we have them everywhere in the world. These are groups where you could enroll patients in something lower risk, minimally toxic, to prevent that development of the solid appearing lesion, the malignancy, maybe potentially improve other outcomes.
Use some drug, right?
Sorry?
Use some drug to prevent the disease.
We'll work on that, but we want to work on that with you. Yeah.
Good.
I think we're close to. Do we have any questions?
Okay, so I think we're perfectly on time with this session. So I'd like to thank all of you for the excellent presentations and giving us an update on what's going on in the current therapeutic fields and for these excellent discussions. Are there maybe any final questions from the audience?
Martin Skrzypski, please.
Hi. So, Natasha, you mentioned amazing digits, 45% stage 1A in Toronto. So it's a large segment. And so I think that it's more important than ever, the issue of prognostic signatures. And are you aware of any signature being developed for the purpose of choosing the subgroup of stage 1A for adjuvant treatment?
So it's a great point, Martin. So great to see you, by the way. And Karen showed some of the nice data that are going on where they've showed some signals, and of course, there are pathological risks, and the surgeons are very interested in this risk assessment. We've been looking at ctDNA as a way that increased risks, whether it's that you're higher stage than we think, and we should reflex to better EBIS or just preoperative therapy, or if that should be a factor, and those trials are ongoing. But I agree that radiomics. There are a number of different things. Somebody said to me the other day that, we shouldn't use prognostic markers, we should use predictive markers. But I actually think in such early stage disease, we start with prognosis. That's how we find high risk, and we go from there. So I think there's a lot going on. Are we doing all the right things? I don't think we know, but if what we're doing now doesn't work, we're going to come back to you. How about you? What are you interested in? What are you doing in your lab and your work?
Well, we're working on NRF2-KEAP1 signature. This is more of a predictive marker. So basically, it's a marker of resistance to everything, like chemo, radio, and immunotherapy. But now I'm thinking that prognostic signature is probably the way to go for this increasingly growing population. So there is Oracle from Swanton Group, and then there is Canadian, Toronto. Yeah, the Princess Margaret. You've produced some signatures, and all those signatures were kind of put aside for a long time. Maybe it's time to revisit this issue.
I agree. It sounds good.
Thank you.
Thank you. I want to compliment all the speakers, but as probably the only pathologist in the room, I'd like to draw some attention to understanding the non-solid and the part-solid lesions, because that's only known now to a limited extent. And I think, and I'll explain later in the presentation, that large part of the lesions which are non-solid are actually adenocarcinomas in situ. And in the part-solid lesions, which are a large lipidic component, you can still wonder whether the current interpretation of the radiologist, like white is invasion, is correct, since you got also a stromal response, which may reduce the amount of air, and therefore it becomes white instead of through invasion making it white. So there's more to understand also from the pathology side.
Eric, we were talking last night at dinner about how important it would be, especially with that as the lesions deflate and everything becomes mushed together, that sort of preoperative, the radiomics, what other things do we need to be doing so that what you get at the other end, that you fully understand what it is that you're receiving and what the chances are of things being invasive or non-invasive, rather than just having to guess just because things are squished together. I don't know, are you guys doing that? And I feel like you would be doing that. Are you guys integrating radiomics and pathology?
No, I'm afraid I'm quite ignorant about it, but I don't think it's ready for prime time. There's a lot of research going on, so.
Okay, thank you. So we will conclude this session and directly move to the next one, the therapeutic case review.